Hello, welcome to the Let's Talk Kids Health Facebook Live Show, episode 38. I'm Dr. Nerissa Bauer, your host. I'm a behavioral pediatrician and blogger of Let's Talk Kids Health. As you know, the concept of this show is to share information about behavioral health, parenting, and family wellness. Each week, I plan to bring you topics and guests to help me advance this mission so that we can all talk together. Now, let us know that you're here by commenting, asking questions, and liking at any time. And in a little bit, your questions will be asked to my guests. The replay will be immediately available after the broadcast. Now, please share this episode with anyone you think who would benefit because sharing is caring. And if you don't want to miss future episodes or maybe check out some of my past ones, please subscribe to my YouTube channel, Nerissa Bauer, MD, and follow my blog Facebook page, Let's Talk Kids Health. Okay, so now on to this week's guests. I have two today. Let's welcome Dr. Julia Schechter and Dr. Scott Kollins. Dr. Schechter is a licensed clinical psychologist and assistant professor in the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine. Dr. Schechter is a faculty member in the Duke ADHD program, where she participates in research, supervises clinical trainees, and provides clinical services. In her clinical practice, she specializes in the empirically supported assessment and treatment of developmental, psychiatric, and behavioral disorders, particularly ADHD. She is also co-director of the recently launched Duke Center for Girls and Women with ADHD. Dr. Scott Kollins, who is the Chief Medical Officer of Holmusk, the world's leading real-world data company focused on behavioral health. Prior to this, Dr. Kollins spent more than 20 years on the faculty in the Department of Psychiatry and Behavioral Sciences at the Duke University School of Medicine, where he maintains an adjunct faculty appointment. He has published more than 180 scientific papers, and his research has spanned a number of areas, including human psychopharmacology, ADHD across the lifespan, nicotine, and other substance use disorders, as well as clinical trials. Dr. Kollins has been a leader in designing novel approaches to support clinical evidence generation for digital therapeutics. He received his undergraduate degree in psychology from Duke University and his graduate degree in clinical psychology from Auburn University. I am so delighted to have both of you here tonight on the show. Welcome.
Thank you. Nerissa. Great to see you again.
Yes, thanks for coming back. And Julia, welcome for the first time.
Happy to be here.
Yeah, and what a wonderful way to kick off October, because October, as you know, is ADHD Awareness Month. And I couldn't imagine a better set of guests to help me introduce this topic where we're going to be talking about ADHD in girls. So, without further ado, why don't we go ahead and get started? Because I think there's going to be a lot of questions about this. So, can girls have ADHD? Isn't it just a boy thing?
Yes, girls can have ADHD, and they can have the inattentive type, the hyperactive impulsive type, and the combined type, where there are difficulties with both inattention and hyperactivity and impulsivity. There definitely is a misconception that this is a boy thing and that only boys can have this, but that is not the case. Girls absolutely can. Boys tend to get diagnosed more often than girls, so about 3 times more often than girls. And that is for multiple reasons that we'll talk about tonight, including the presentation that girls have of ADHD. It is different in girls with ADHD. It looks different, and also just historically, what we've studied with mostly is with boys, hyperactive white boys, and so that's absolutely affected the way that the world, including clinicians, have seen ADHD. But it absolutely can be and is present in girls.
Yeah, I would add on top of that too, Julia, in terms of the differences in the rates of diagnosis. I mean, it is in kids, it is actually diagnosed more frequently in boys. But a really interesting finding is if you look, if you measure that by looking at kids that get referred to their pediatrician or to a specialist, you see that number that Julia mentioned. There's about 3 times as many boys that get diagnosed, maybe even a little bit higher. But if you actually go out into the community and do a study where you just try to assess everybody out there and you look at the rates, it's closer to 2 to 1. So clearly there's a lot of girls out there that aren't getting identified and diagnosed. And then when you get into adulthood, the rates of diagnosis actually even out. So the rates of ADHD diagnosis in women and men in adulthood are about 1-to-1.
Yeah, thank you for that. And I think there's going to be a lot of questions about the presentation. So, what does ADHD look like in girls, and why is it so different than in boys?
Well, you want to? I'll take a crack, Julie. You can,
Okay, yeah, that sounds good.
Yeah, we could spend a lot of time talking about this, and I think Julie alluded to some of the differences. I mean, some of it has to do with expectations and the way that this condition presents itself. As Julia said, I mean, the girls are somewhat more likely to be diagnosed with inattentive type ADHD, and as many people probably know, the symptoms that are associated with that have to do with not paying attention, being distracted, being forgetful, losing things. It's oftentimes not the symptoms that are overtly causing problems in a classroom setting. And far and away, the main source of referral and the reason that kids start to get on people's radars for having difficulties is having challenges in school. So I think about it as the inattentive girl that is sitting in the back of the class, not causing problems for the teacher. They're going to be a lot less likely to get referred than the boy that might be more likely to be exhibiting hyperactive impulsive symptoms, up and out of their seat, making noises, things like that. But Julia, what would you add on that in terms of the presentation?
Yeah, absolutely. No, they're much less likely to cause waves, right, in the classroom and get that attention, to get the referral. There's also just in part because of societal expectations, girls tend to, they are expected to be organized and to follow rules and to pay attention. And so girls with ADHD develop a lot of coping skills typically to try to mask some of these difficulties, even though these are very, very hard things for them to do. They're trying extra hard to cover up these difficulties, which leads to further delay in people knowing that that's what's going on. There also, research has shown that the girls with ADHD tend to have more internalizing symptoms, so more anxiety and depression. And that is typically what gets them seen by a mental health provider. And so they might get that diagnosis of anxiety and depression before ADHD is recognized and diagnosed and treated. We also tend to see that the girls often have more emotion regulation difficulties. There's some evidence to suggest this as well. And so that further is going to kind of cloud the picture a little bit in terms of the ADHD.
Yeah, and getting back to something that both of you said, I think a lot of kids or girls often tend to have like that perfectionist tendency, and teachers are often unaware of the fact that, maybe she sort of waited till the last minute to get something done and stayed up, until 3 a.m. to get it done, but it's perfect because she had to really get it to meet other people's expectations, and teachers totally unaware of that pattern of behavior, that inability to prioritize, organize, use their time well, to be able to remember to do when things are due.
Yeah, and I would add on top of that too, just thinking about some of the things that Julia and what you just said, Nerissa, how they manifest in kids. If you fast forward as these girls become women and young adults, the additional challenges sort of mount up. So from a clinical perspective, I can think of lots of specific sort of prototypical cases where you've got a girl that maybe they were diagnosed with an anxiety or a mood disorder when they were younger, and maybe that was a true disorder, or maybe it was secondary to just struggling with ADHD, but they were never diagnosed with ADHD. That snowballs, and then they get into adulthood, and they just things are they're not functioning in a way that they know that they can, and getting an ADHD diagnosis in adulthood can also oftentimes be just like in some ways an epiphany, but also just cause a lot of frustration and regret, like, gosh, why didn't we figure this out earlier? But that definitely persists into adulthood.
Yeah, there's definitely this this idea that, oh, well, you did so well in school as a kid. There's no way you could possibly have ADHD now as an adult woman. And so during these evaluations that, that Scott and I, do and have done, really trying to talk to women about what was their process like? What was that experience like at home at night when they're trying to get all these things done? Because on paper, it's not always obvious.
Yeah, and I think during that process too, sometimes when families are bringing their child in for that evaluation, it can oftentimes spark introspection, and then they realize, oh my, oh my goodness, maybe I have ADHD.
Oh.
Yeah, all the time.
The number of times that I've seen that, when we're giving feedback after an evaluation for a child, and you're talking about the fact that ADHD can also be genetic, and you see literally these light bulbs flashing. A lot of times it's the one parent looking at the other and saying, now I know where they got this, but a lot of times and especially for our topic tonight, for the moms and the women, it's a common thing.
Yeah, and I'm so glad that we're talking about this today, because I think it's important to bring awareness to that. And, I think too, I mean, I can think of, families in my own practice where moms would come in afterwards and say, guess what? I got the diagnosis too, so I'm ready. We're working on this together.
Yep.
So, yeah. And so I'm going to ask you, I mean, is it true that then girls are like less often diagnosed, or is it that they're just missed, or is it a combination?
Go ahead, Julie.
I was going to say it's definitely, it's a combination of they are often missed because their symptoms are more subtle and less apparent to others. And so again, things that might be a little bit more apparent, like that emotion dysregulation or the anxiety, often kind of rises to the surface, and people think that's what might be going on, when there might be that either co-occurring or underlying ADHD. And also there's again, this kind of misconception, even amongst professionals, that the girls can't have it, or because they're doing so well in these other areas that they can't possibly meet criteria for the diagnosis. And that leads to misdiagnoses. It leads to delayed diagnoses. And we know this is really impactful for girls. Research has shown that girls who are not or untreated are at really high risk for negative outcomes. So eating disorders, suicide, self-harm, unplanned pregnancies, trouble in school and work. It can be really, really negative if girls are missed.
Yeah. So, I mean, in terms of what can parents expect, right? I mean, so if they're thinking that they have concerns about ADHD in their daughter, I mean, what would you recommend parents do at that point in time?
Yeah, I mean, I think that the kind of starting at the very top, like most other mental health or other kinds of physical concerns, talk to your doctor. Talk to your pediatrician first. Try to get as much information as possible, and kind of go from there. But I think waiting and watching is not a good strategy. It's for all the reasons Julia just mentioned.
Yeah. I also often recommend that parents definitely start with pediatrician, but you can prepare even ahead of that appointment and talk to people who know your child well. So teachers, coaches, babysitters, someone else who knows your child and who probably also has experience with other kids. Because sometimes it's hard as a parent, you have you only have your kids, right? Or your one child. And so having professionals who can compare your daughter's behavior to others can be really helpful. And you can kind of go into that appointment, equipped with that information to share with your provider.
Yeah, Julie, I'm so glad that you mentioned that, because actually I was the spokesperson for the American Academy of Pediatrics for an initiative that was done by Understood, as well as in partnership with the AAP. It's called Take Note, and it's a really great resource. It's actually in its second year, and we have a ton of resources on there. And the idea is to help empower parents as well as teachers and professionals to take note, to notice, observe, talk, and engage. So that way we can help provide a framework for parents who, might not know what is important to report. And they, it's very confusing. Like, I don't know, I only have 15 minutes with the doctor. So like, how much of this do they need to know? What should I report? How do I do this? So it's a really nice framework. There's a lot of resources on there. It's available in English and Spanish. And it really does promote sort of that, multidisciplinary collaboration and gathering all that information from other people. Because you want to be able to show these symptoms and behaviors across settings, how long it's been happening, how it's impacting your child. And, usually we only have that our own view, but it's so helpful when parents have all that information ahead of time.
Yeah, that's great. And all the things that you just said, Nerissa, as you know, I mean, those are the specific things that, your doctor, whether it's pediatrician, psychologist, psychiatrist, those are the exact things that we're going to be focused in on to sort of, evaluate and make a diagnosis. What are the behaviors? When are they happening? Are they happening across multiple settings? How much problem are they causing? How long have they been going on? So yeah, that's great advice. That's a great initiative.
Yeah. So I'm starting to see a couple questions. So remember, if you're watching this live or listening, either on Facebook or YouTube, please feel free to say hello and then also drop your questions. I'm going to go ahead and share this one from Luke and Kelly. What age is ADHD considered a suitable diagnosis as opposed to just behavior being age appropriate?
I can. I'll start with that, Julie. I spent a lot of time in my research and clinical career studying preschoolers with ADHD, and so I think the short answer is probably the youngest that you would be able to make a reliable diagnosis of ADHD is probably 3 or 4, and that is still pretty young. My general recommendation to families is if you've got a kid below the age of 6, 3, 4, 5 that you have concerns about, talk to your pediatrician, but think about maybe getting connected with a specialist. Just because making a diagnosis at that really young age, it can be tricky to make that differentiation between, okay, what's typical behavior and what's clinically significant. But just as we're talking about, ADHD being very real for girls, it's also very real for young kids, beneath the age of 6. So same principles. If you see things, take note, talk to your doctor, because that early identification and early intervention can make a big difference.
Yeah. I think that's such a great question. And I think, Scott, anecdotally, I think you'd agree that oftentimes when we see kids, there's this narrative of like, well, they've always been this way. I mean, typically, like parents notice early on that something feels a little bit different. And I've also just anecdotally in my practice too, of people have come in and said, well, we were told we couldn't get a diagnosis until he or she was a certain age. And that's not true. You can get a diagnosis earlier. And really importantly, like you said, Scott, early intervention can make such a big difference. So diagnosis, no diagnosis, there's still absolutely things you can do even for really young kids to help with managing behavior.
Yeah. And maybe when we get down to if we talk about more broadly about treatment, we can talk about some of because there are some considerations for treatment for young kids, compared to older kids, but treatments are available in general.
Yeah, so thank you for that question, Luke and Kelly. I hope that answered your question. All right, well, why don't we go there then? Let's talk about treatments. What treatments are available for girls with ADHD and then more broadly, especially for those subpopulations like the preschoolers?
Yeah, well, maybe I can start with a more kind of a generic answer around treatments for ADHD, because there's not a lot of specifically empirically supported studies and research supported interventions just for girls with ADHD. But in general, and Nerissa, you know this as well or better than Julie and I, being so involved with the American Academy of Pediatrics, but there are pretty specific guidelines and best practices around using medication. So medication is a frontline treatment for ADHD, as is the use of behavior therapy. And in kids, that means usually working a lot with parents and doing behavior modification. As kids get a little bit older, there starts to be more of that work that's done jointly, and then in adulthood, it's sort of one-on-one with the adult patient. And then there are also, like we talked about the last time we were together, Nerissa, there's a couple of new interventions on the block for ADHD that are devices. One's an app-based video game. One is a non-invasive, very safe nerve or brain stimulation device. So there's a lot of options that are out there.
Yeah, and I would add that, there are options out there, and there is, they work equally as well for girls and boys, and so that is the good news. Like Scott said, there's not empirical evidence to suggest that a certain treatment would be used with a girl with ADHD versus a boy. But I think when we go back to that, girls with ADHD do tend to have more internalizing symptoms. That is just something to consider when you're thinking about treatment. So it might be coupling the behavior therapy with some sort of, CBT for anxiety, for example, and or kind of just thinking about, is there some other medicine that might be used in conjunction potentially with a stimulant?
Yeah. And I'm so glad that both of you, sort of talked about treatment kind of more broadly, because the things that I consider being a behavioral pediatrician, I always talk to parents about the five pillars. Yeah. Self-care. What are some of the things that we can start teaching our children now to develop healthy habits around eating, sleep, and physical activity? Because those are things that we know that can boost mood as well as their focus, as well as then medication, as we talked about briefly. And then parenting support, that's always going to be true, because as we know, the executive functions that we know are deficits or challenges in individuals with ADHD, our frontal lobes are still developing until the mid-20s. And so as parents, we need to move from being, a manager to more of a consultant, but we're still always going to be involved in some capacity. So we've got to support our parents as well. And then that behavior therapy, especially as children, become much more mature and get older, we want them to have that self-advocacy skills. And then also, just the educational accommodations too. What are some of the things that the child is going to need to be able to function and learn in school and still be happy? Because we know that school is probably the biggest stressor on kids' executive function, because that's their job during this time. And, it changes year to year. So we've got to talk about those things every year, and it might change the pieces of the puzzle, but we just have to keep talking.
Yeah, absolutely. Yeah, it's that kind of chronic condition framework of like,
Yep.
how do we continue to sort of figure out what are the needs right now, and how do we address them as girls and people just get older.
Yeah. No, and I'm glad you mentioned, Nerissa, just the more kind of a more holistic approach. Just I think about treatment fairly in a circumscribed way about what do we know from a FDA approved or an empirically supported, and although there is actually a lot of support specifically for ADHD around exercise as being beneficial, and even if it's not beneficial specifically for ADHD, it's beneficial for life. I was just going to make one additional comment coming back to what we were talking about with the young kids. I mean, the one difference from a treatment planning perspective in the really younger kids in preschool age is I think that in school age kids, I think our routine recommendation with a new diagnosis, behavior therapy and medication, along with the other things that you were talking about, Nerissa. With younger kids, I am much more likely to recommend maybe and some of this depends on the severity level too, but much more likely to recommend starting with some behavior therapy, evaluating whether or not the need is still there, because you can make a lot of progress in young kids. Now, that's not always the case, and a lot of times, and by the time kids make it into one of our projects or into our clinic as a specialty clinic, a lot of times the severity is high enough that we need to think about medicine just to kind of help get the symptoms under control, keep kids safe, and that sort of thing. But I think that there is, what's considered frontline, give a little extra thought in those younger kids.
Yeah, for sure. It looks like we have another question, this time from Dr. Melissa Holmes. How does progression through puberty typically affect medication dosing?
Oh,
this is such a good question.
Dr.
And,
Holmes, thank you so
yeah.
much for the question.
Yeah. And I think right now there is emerging evidence that hormones really do play a role in symptom presentation of ADHD. So we certainly know that girls are going to show, just you're more likely to see symptoms just around transitions in general. So transitioning from grade to grade, transitioning through puberty, things like that. But again, there's just some emerging evidence that's showing that specific neurotransmitters really do seem to play a role in how symptoms are looking. I know that there are studies out there that are actually even looking just across the menstrual cycle and seeing how symptoms fluctuate even within the monthly cycle. This research is still kind of new, and I know there's some really good studies out there that are being run currently to better understand this. But I also think it's certainly worthwhile to have these conversations with your medical provider.
Yeah, I would add on top of that. We've actually done a little bit of that work a few years back now, but it's super interesting because there's an interplay between ovarian hormones and the dopamine system, and the dopamine system in the brain is the neurotransmitter system that we think is pretty centrally involved in ADHD. It also is the target of most of at least the stimulant medications that are used to treat ADHD. So that then leads to the question around dosing. Julia, you effectively avoided answering the question. And no, I'm teasing because I don't know that we have a good answer specifically at a sort of at a general level what to say about dosing. I think that's probably one of those things that there's going to be a lot of individual variability. Neither Julia nor I are writing prescriptions, so maybe we'll put our host on the spot from a clinical experience standpoint. From in dosing, what's your experience with that?
Yeah, so mine is always, I think mine is always going to be the same regardless of if they're going through puberty or not. My approach whenever I start medication is always to start low and go slow, but at the same time making sure to educate both the parents as well as the patient themselves what the medicine should be working on, if it's having a positive effect, what side effects to be monitoring. And then I always tell my patients too, there is a number that you could dose to, but I kind of keep that in the back of my head. Like I never dose these types of medications to that number, because I always tell parents and clients that, if we're doing well on, 15 milligrams and, school's going well, you feel like you're on top of your game, why go up any higher? If you're not having any side effects. My whole goal though, through whenever I meet with families, is to really check in, not just with the parents, but with the child, as well as then getting rating scales from the teachers, and then always monitoring, like, how is that child functioning? Because I think that's going to be the single biggest predictor of whether or not we need to adjust the dose, regardless of, if the child's 7 or 13 or 17, right? I need them to be able to function and do what they need to do. All right. Well, so, I have some other questions in terms of, it is ADHD Awareness Month, and I am so excited to talk about this whole new center. Tell us about this and why the decision to do this work.
Yeah, I can start. This was the vision of a generous and concerned donor that reached out and had some personal family experiences with ADHD in girls, and saw firsthand, as somebody with resources and means, how difficult and challenging it was to find the right kind of provider and get the right diagnosis, to find the right educational setting. And we started a conversation about, what is the need and what is out there. And we talked a lot and sort of, together shaped the vision of what we really wanted to do. And what we sort of honed in on was that Julie and I, we work in an academic setting. Our kind of bread and butter is doing research, and there's lots of different sort of mechanisms to get research funding to do studies and things like that. There is precious little funding to really, really focus on building resources and building educational educational resources, building awareness. So that is the mission of the center, is to raise awareness, to provide a place where people, a one-stop shop where people who have questions or concerns about themselves or about their daughters with ADHD can come and get information. Ultimately, to get information maybe specific to where they might look in their own communities to find resources. So that's sort of where this all started. It was probably about a year's worth of just back and forth and discussing and thinking about things, and then we launched early this year as a center. There's a lot of buildup in terms of starting to build the pieces of this. So we've been working for the last 9 or 10 months on getting that up and running. But I don't know, Julia, if you would add anything.
Yeah, and you mentioned this is a resource for individuals and parents and families. It's also going to be a resource, we hope, for clinicians themselves who might be less familiar with what ADHD looks like in girls and women as well. Also for educators and just the general public. We want this to be kind of a resource hub for everything. Like Scott said, a one-stop shop to get reliable, evidence-based information about girls and women with ADHD. We also, we will be putting out our own content. We already started to do this on our social media, but we also, our goal is to really bring people together, experts in the field, really reputable organizations. So like working with you, Nerissa, and then working with CHAD, the Child and Adult ADHD organization, as well as APSARD, so the Association for
American Professional Society for ADHD and Related Disorders. It's not easy to remember.
It's not right, exactly, but it's APSARD, and they're wonderful. And so we want to bring all of these wonderful pieces of content and all of this knowledge base to one place. And so people don't have to go searching all over the internet and decide, is this reliable or not? They come to our site and they know that they can, that will be a valid and reliable piece of information.
Well, I'm going to share that website with you here, so you can go to that website. You can follow them on social media. They have an account on both Instagram, Facebook, and Twitter. And I'm sure you can get on their mailing list, so that way you can keep abreast of everything that they're going to be offering. So I'm really excited. I think this is I love that story, Scott. You talking with this family who, from their own personal experience, wanted to give something back, and they recognized that this was a gap in the services, and just wanted to, make it easier for other families moving forward.
Yep.
We know that the quality of life for families with children with ADHD is lower. Research has shown that. And we know that, getting back to the topic of medication, even though medication can decrease the severity and frequency of those symptoms, there's still going to be residual issues in the family with peers. Just the executive functioning issues can really cause some stress and strain for a lot of individuals with ADHD.
Yeah, for sure. I wanted to come back to just one other thing that popped in my head while Julia was talking too. For all the people watching, obviously you're tuned in for a reason. You have an interest, personal or otherwise, in girls and women with ADHD. Part of our center's mission is also to, like Julia said, to bring people together, and we'll be rolling out in the coming weeks and months a lot of content where we're trying to think about what are the kinds of things they're going to be useful. And so we've got, whether it's ADHD in preschool girls, or whether it's ADHD and girls from underrepresented racial and ethnic minorities, or women in the workplace. But we'd love to hear from you and from people about ideas or questions that you have. And the more we get from that, the more we can shape and tailor the content and the information that's going to be useful for the broader community.
Yeah, I guess I'll just ask this question because I have heard this before in other episodes. There's questions of, ADHD and autism
Hmm.
in women, and that one is often missed a lot as well. Do either of you have any comments on that?
Yeah, Julia, you have,
Well, yes. I mean, that is, you think about masking, right? Like these girls that have ADHD are trying so hard to fit in, and we know that is the case with autism as well. It's really similar in terms of these girls getting missed, higher rates of diagnosis in boys. It is complex, of course. I mean, I think that diagnosing autism in girls is typically more challenging, same as we see with ADHD.
yep.
Scott and I happen to be involved actually in a study looking at the combination or the co-occurring ADHD and autism in young kids. So this is definitely something that we've thought a lot about.
Yeah, and I was going to say, and it does. I mean, the numbers are may be surprising to some, but roughly half of kids who get diagnosed as being on the autism spectrum are likely to meet the criteria for ADHD, and a significant proportion higher than what you'd expect in the population who have ADHD are also going to be presenting with on the spectrum. So definitely something to take into consideration. One of the things that, just from a clinical perspective, that also makes it challenging, in addition to the masking, is we know that kids with ADHD in general, and especially girls, they struggle a lot with their social interactions.
Yeah.
And that is one of the hallmark features of autism as well. So sorting that out and figuring out, and it's super important to get a good and reliable diagnosis to make sure that you're targeting the right kinds of things, and because there are some differences in the kinds of interventions that you would want to use for kids that are comorbid for ADHD and autism versus ADHD alone.
Yeah, that's right. And then we had talked earlier how ADHD and anxiety can overlap too. And those kids with social anxiety in particular, they can have
Sure.
those social difficulties as well.
Definitely.
I mean, I think it's important to point out that, for parents who are listening and, might feel really overwhelmed about, like, gosh, how do we even know? And things are going to be missed. I just want to point out that oftentimes when you start going down this road, it's not uncommon for a child or an individual to get diagnosed with one or two things, and then we continue to monitor because certain presentations, behaviors can come out later and then be diagnosed later with like a learning disability and all of that. So can you speak to that a little bit about kind of the evolution of the diagnostic trajectory sometimes for these families too?
Yeah, I mean, I think my start would be just that, like we talked about earlier, is that the diagnostic trajectory definitely isn't necessarily, smooth and linear.
Right.
And that, ultimately there, girls are often diagnosed with something else before ADHD is recognized. And that is also, since we were talking about autism, same with autism as well. And so I think, the message to parents of, this might not be, there's ongoing monitoring to do, and continuing to keep an eye on these symptoms, talk regularly with your providers, continuing to get feedback from schools, and so that you can figure out, is there something else that we're missing here, and at what point do we what data do we need to see before we pursue potentially an additional evaluation for something else?
Yeah, and I think what I would add to that, I had 5 different things that popped in my head when you asked that question, Nerissa. So let Julia take the first swing. But what I recommend, and I'm thinking now more because clinically as specialists, by the time people come to us, they're something's happened that ended up getting referred to us, versus probably the discussions that you might have, Nerissa, being more sort of upfront primary care. But the threshold for me, if I get questions from people I know who say my kid is XYZ, my threshold is always is it causing problems? Is it causing problems at home? Is it causing problems at school with peers? And even for a kid that's already diagnosed with ADHD, where there might be some of those issues, if there's something else that's now being noticed, just think about, is this above and beyond what you're seeing with the ADHD? And I think that's a good litmus test to really, because these comorbidities and these co-occurring problems happen so frequently. It is important to pay attention to, but at the same time, we don't want to over pathologize and over ascribe problems that kids that might be just sort of routine fluctuations.
Yeah, agreed. So, I mean, like we said, I mean, this is a complex thing, and right now there's not a imaging study, a blood test, or a swab test, to say, hey, it's this, right? And oftentimes it takes a very good, history, other data that you're collecting across multiple informants, and then just really good observation and keeping tabs on things. So, like we all had said earlier, it's important to just keep talking and keep observing.
Yeah. And I would add also, I think something that we want to do through the center is actually, create some support groups, some peer support groups, and those exist as well out there. But I think continuing to, get support and get support from other parents who potentially have similar kinds of concerns for their kids can be really helpful, both just, for your own mental health, but also for getting some ideas of how this might present in other kids and other resources that might be available in your area. So it's really important to do.
Well, I wish you all the best. I mean, this is going to be this is a huge endeavor, and it will be really wonderful once you guys are like all the way up and running, because I am looking forward to seeing all the content that you're putting out and really making this dream become a reality. So thank you for the work that you're doing.
Yeah, thanks, Nerissa. We'll count on you to help spread the word and get the word out, and we'll circle a date next October, and we'll come back and give you an update.
Yeah.
Let's do it. I'm gonna throw the website here again one more time, just to make sure that if you're watching this, please make sure to check out that new website and follow them on social media. It looks like we might have one more comment here. Hold on one second. Oh, thank you, Dr. Holmes, for that feedback.
Thank you.
Thank you. And let me make sure. So that way, I do want to mention too that my next week's special guest is Renee McDougall, who will be talking to me about empowerment in teens. And then also, since I just want to always make sure that we also collect all the guests here and we keep talking. So if you know anybody or have a guest who you would like to recommend or a topic, please feel free to reach out to me on my email, Dr. Nerissa at letstalkkidshealth.org, or just drop me a message on any of the social media platforms that I'm at, because I'm everywhere. So again, it was a pleasure talking to the both of you. Thank you so much. And, like I said, I'm looking forward to everything that you guys are going to be doing moving forward. Thanks so much.
Thank you for having us.
Thanks, Nerissa.
Thank you.